Jamestown this morning?
Pardon?
You were in Jamestown today?
Yeah, up to 1:30.
You need an automatic car. Or whatever those are, self-driving. Wow. Okay, it's 9 o'clock and I'll call the Neighbors of Dunn County committee meeting to order. It's been noticed properly and I think we're ready to go. Everybody's here except Larry Bjork, who called in and said he wasn't going to be able to make it today. So the minutes were sent to all of us. Anybody have any changes or additions? I'll take a motion then to accept that. Supervisor Witzel
I so move.
moved and Supervisor Keeter seconded.
Yeah.
All in favor? Aye.
Aye.
No opposed, I see. Okay, was there any public comment? And number 5, at my request, the request of the chair, a CNA course update. Just as a reminder, we've been looking to get one in at the Neighbors. Carmen?
Sure. All right. So currently, as I talked about a couple weeks ago or months ago, I guess, we have been doing the application through Ready CNA for a program at the Neighbors. So we are partnered with that company that has an online training course setup platform kind of thing that then we'll be able to utilize. The cost for that is just by registered CNA student. So that would go to the student for the fees. And we're all set up through them. Now we're working on the approval process with the state. To have an approved program, we also have to have an approved instructor before they'll approve our program. So we've done a little bit of searching for an instructor. At this point, we're actually looking at working with HR and the county as a whole to develop a specific position for this instead of placing them into one of our nursing positions and having it be an actual trainer nurse that would do the CNA course as well as do ongoing training for our current staff, as that is somewhere that we can see kind of a hole right now that we're pulling nurses from the floor to do that and different things. So this person would do the CNA training course would be about 50% of an FTE. Then the other 50% would be doing our annual required trainings, doing any trainings that are required due to any quality concerns or citations, which anytime anything like that occurs, we have to do all staff training. And then also for doing audits of CARES, skills audits, and then doing training for those. Then every year, we used to do a big skills fair. Unfortunately, we haven't had the staff to be able to do that in the past couple of years. We don't have extra hands on deck. So this person would also be the lead person for the skills fair, basically competency skills for the nursing department, which we're now currently doing on a person by person basis because we have to do those skills competency testing. But we haven't been able to have kind of a big collaborative group situation. So that person would be in charge of doing that. So right now we have completed the JDQ, which is the county's new form for requesting a new position or title. We did those for all of our positions when we did the class comp study last fall. So we completed a JDQ for that, and that was sent over to HR. So that's being reviewed by HR right now. The process for that is going to be, it would have to go to this committee, hopefully next month. It goes to the consultant that does the JDQ building of a position, gives us a dollar amount or a step on the pay grade. So it would tell us where they would fit into the Neighbors pay grade. And then that would come to this committee. And then it would go to the Committee on Admin and then County Board. So it would still be a process. Timing wise, it actually will work out fairly well because it can go to this committee and then County on Admin on the same day. So we'll have it, the County on Admin meets the same day as us. So in the afternoon, so we won't have to wait potentially up to a month is kind of the situation that has happened in the past of trying to make dates and times and meetings work. So it'll go on, once it's on our agenda, it'll also go on that agenda as a tentative item. So if it gets approved by this committee, it would go to the County on Admin's committee the same day. So, and then it would go to exec and county board that month. So hopefully shortly we will have that in place, and then we can keep moving forward with that process. So that's where we're currently at on this. I know Chairman Kinnear did bring up something a little earlier about the CNA training course that's going on in Eau Claire right now, which is kind of an expedited course. They, instead of doing it over multiple weeks, it's a 2-week time frame. So it's also through a similar company to Ready CNA, but just a different company that then will be doing their classes at some of the Dove locations in the Eau Claire area as a very fast course. It's still the required hours, but it's done more on a full-time training basis for 2 weeks instead of the extended courses that are typically held a couple hours a day, typically after school or work hours, so that someone can do both. But hopefully, especially since it's summertime, college students, even high school students would be able to do that as well. So that's my updates on CNA training course. Does anyone have questions for me on that at all?
Yeah, thank you very much. It looks like you're solving more than one need with the idea of a position, a bigger picture look.
Yep.
That's nice. Right now, if you have the person-to-person training, there's the possibility, isn't there, of 2 people for the same position could get trained a little differently depending on who did it?
That is possible. So we typically do have a very small group of people doing the training. So it's depending on the training. It can either be myself, Paula, our director of nursing, or the 3 ACMs. And then we do have a couple other nurses that have been with us a really long time and also participated in the skills fairs in the past. And helped with those that have continued training. But yes, everyone does train slightly different. And it's just also a really good way to have a collaborative group. If you have, say, 5 people at a time going through the training, someone might have a question that someone else didn't think about to ask and things like that. It's always just a little bit better of a situation to have a group go through. And it would save some time for some other people too, which is nice.
What's an ACM?
Assistant clinical mentor. So we have our titles are a little bit different at the Neighbors compared to most skilled nursing facilities. So I am the administrator, but I also hold the title of community mentor. So that's like what it says on the county's pay grids and lists and things like that. So our clinical mentor would be director of nursing, which is Paula. And then we have 3 assistant clinical mentors, which are 1 for each neighborhood, which is kind of a mix between a director of nursing and an assistant director of nursing. So we do operate as one campus. So we kind of have a campus view of it as one big nursing home. Then it would be Paulo as the director of nursing. But in the state's eyes, all 3 of our neighborhoods are separately licensed. So we have to have a director of nursing for each. So that's why we have 3 assistant clinical mentors.
I can't remember if Sean, you brought this up or Corley or who brought it up, but as we go forward here and if we get that position or Eau Claire, have we discussed defraying some of the students' costs, scholarship, if they work for a certain length of time or?
So we haven't gotten that far yet for like actual discussions with HR or anything for how much we might defer or timeframes or things like that. It has been brought up as an idea of doing kind of like a scholarship thing. It's been brought up a couple times of potentially doing, if we have any internal staff, say we have homemakers that do it, we would offer a scholarship to those staff that if they're moving from a homemaker position into a CNA position, to motivate people to advance their skills and get a new position and new certification. So we have discussed that. that might be an option. We just have not done the costing or anything for that yet.
Okay, yeah, thank you.
Mhm.
Anything else? Anybody on this? Okay, well then, I guess you get to talk some more.
Well, Jane isn't here today either, so I'm going to be talking a lot today. So, okay. So Quality Assurance Steering Committee updates. So as always, we met for a Quality Assurance Steering Committee this month. The reports this month were both Quality of Life, which is one of our subcommittees. And then we also had a report from our Safety Committee, which normally would have been last month, but we had to defer it due to meeting conflicts and things like that. So both of those reports were given with no concerns or big issues. The one thing on the safety report that we're working on is severe weather training. We had severe weather this year earlier than most years. So we had on-site and at the moment training for severe weather this year, but we're also going to continue with our regular severe weather training as well. And then the other thing that came up was UTI management. So urinary tract infections are a very hot topic in nursing homes. And we have had a slight increase in one of our 3 facilities, and then a little bit in the other 2, but we are doing audits of cares and everything like that to make sure that our staff are doing what they should to prevent UTIs, which all of those have come out okay. Our physician that attends our Quality Assurance Steering Committee meetings discussed with us some ideas of that we might be over testing for UTIs with some statistics about the percentage of individuals that have UTIs at over a certain age is extremely high, even if they're not symptomatic. So we had a fairly long discussion about the hospital's approach on UTIs versus our approach on UTIs, and trying to figure out best practice. So it was a really good discussion. And then we also talked about COVID situations, which I'll get into a little bit later. Any questions on QA?
And UTIs are urinary tract infections?
Yep.
For people that might watch our.
Yes,
Yeah.
yep. A UTI is a urinary tract infection.
Okay,
Alrighty. Next is the employment report. So I'll have Chris talk about that one.
Good morning. Can everybody hear me?
Yes.
So for May, go through the types of recruitment. Those were the normal ones. I will throw in for June. This week I did go to the job fair at the Judicial Center. So that's been the first job fair since the pandemic started that the Judicial Center has held. So that was kind of nice to get back into that, get our name out there again. Go down to number of interviews and such. We had 5 direct hire interviews, 10 agency interviews. We had 4 positions offered, 4 started. They all had a July or June 1st start date. So I'll try not to include them on next month's report too. So because it was right at the tail end of the month and the beginning of the month. So go down to resignation reasons. It was pretty slow. We lost a couple of homemakers, really didn't give a reason. They were the afternoon ones. It just kind of fizzled out. They were high school students. So I think maybe their time allotment wasn't what we had needed, or we just were no longer interested. We did lose a full-time cook that moved out of state. We can go down to full-time positions. Or open positions. So those were changed a little bit with, the hiring and people leaving. Their number of active leaves of absences went way down because we had students returning, which is always nice for the summer. We had no work comp missed hours for May, so that is always great. And the number of missed shifts in May due to COVID-19 issues, roughly 41 shifts missed, or 370 hours, and that also includes missed hours by contracted staff because they would have to be replaced by somebody. Do we have any questions or?
Of the 4 hires, how many of them were direct hire?
All of them. I don't count the agency people that come as hires. but the positions offered was 4, and those were direct hires.
Oh,
Nice.
thank you.
You're welcome.
All right, next is the resident referral report. So that is on the back of the same page. So the number of residents at the beginning of the month was 101 residents. We had 129 referrals. As you can see, this number is staying high. This is across the state, as I believe probably across the country, but when talking to other nursing homes across the state, everybody is seeing the same thing. We had 24 residents admitted to the neighbors this month, so we did have more than we have in the past few months. Granted, this is for May, so June will look a little bit slower due to some COVID situations and things like that. But for the month of May, we had 24 residents admitted. We had 113 residents not admitted. And just as an FYI, again, those numbers do not always add up because some are readmits and some come in different times versus at the beginning of the month, end of the month kind of thing. So those numbers don't directly add up. At the end of the month, we had 104 residents at the facility. And then we had 0 people transferred to other facilities. We had 4 deaths and 4 discharges. So a lot of those admits were readmits. So people who went out to the hospital and then were readmitted to us. So they wouldn't count in the deaths or discharges. They would just be put back in. So that's why that number is higher without really going that much higher in census. So we have seen pretty much the same outlook on admissions. We have kept our numbers to the amount that we can adequately staff. So we still have 1 household closed. Fireside is open. We are staffing Fireside with enough people to take care of the people who are currently there. So when we've been lower in census, say 5 residents, we will only have 1 CNA staff there versus if we have more than 8 residents, we have 2 CNAs staffed as well as a nurse in both of those situations. So that is where we're at right now. I believe today we are close. We're at 104 again today with a couple of admits. So we will be at 106 at the end of today. It's a little bit difficult because these numbers are always, especially now that our meeting's at the last week of the month, almost a whole month behind. So any questions on referrals?
Yeah, I was just wondering, say, assuming you're eligible, how long is a waiting list now on the average? Is there any?
So for the waiting list, it's a little bit difficult because our waiting list is typically just for long-term care placements, as well as our memory care has a waiting list. So what we do anytime that we have openings that we're able to fill based on staffing, COVID, things like that, in our long-term care setting, we then go down the waiting list and call each person from the start. Typically the first 20 or so say we're not ready yet. They're just on the waiting list because they want to be on the list for the time that their loved one is ready to come to us. So we go through that process. I believe it's about at 35 people right now. I don't have the number off the top of my head, but I can bring that next month.
I was just curious. It's
Sure.
Thanks for bringing the waiting list up, Don. I think I asked you, Carmen, about waiting list and maybe about priority for people from Dunn County. I don't remember if we discussed it as a committee. But did you say that most of these people are probably from Dunn County on
Yes.
the list?
I would say over 90% of our residents, as well as the people on the list, are from Dunn County. We very rarely have people come from other places. We're getting a ton of referrals from other places right now due to everywhere not accepting or accepting very limited numbers of people. But the majority of our residents and people on the list are from Dunn County, or their loved ones live in Dunn County. That's the only time we sometimes have an exception to that, is they may have lived somewhere else, but their daughter lives in town Menominee, so they want to be close to their family. So those are really our only people that don't actually have home addresses of Dunn County is if their family members have home addresses of Dunn County. Any other
Thank you.
questions? All right. Next is the environmental and facilities report. So I'll have Scott do that one.
Good morning, everyone. So we're patiently waiting for survey of East Building. They can come at any time. So Brady has been working on going through things and making sure everything is up to par on that. I've been in contact with Permar for the annunciator panel we've been waiting on. Finally got word from them that they're going to put it on their schedule, although they have not let me know when this is going on their schedule. So I have to get back at calling them, and they're a little tough to work with. But we're making progress. Aside from that, the guys have been working on work orders and typical repairs. We've had some volunteers working in flower gardens, which has worked out quite well. And Alyssa was talking about getting people like an adopt a garden situation for the flower gardens, which I think that would be very helpful. Otherwise, Clint in Human Services has had some teenagers that he has had over there a couple times and will continue to be over there weeding flower gardens, making them look better for the residents. So those things are coming along nicely. Aside from that, everything is business as usual.
Just a comment, Scott gave me a tour the other day and it was a lot of fun. He showed me the guts, which was really interesting. You would have found out. Sean had scheduled it, and we can only do 2 at a time because of numbers test for open meetings. But yeah, I think you will enjoy it if you get a chance to do that. And so he took the time. He was very patient with me. A lot of dumb questions, I'm sure.
No.
But yeah, but so it was very good. Thank you.
You're welcome.
So is there a better days to do this at?
Well, it depends on what you'd like. Would you like guts where you go in and look at the water softeners and the water heaters, or would you like a tour from Carmen that looks at the facility and how it works with the residents?
How long a tour did it take?
45,
45 minutes or so.
and it could have been a half hour if I'd
Oh, okay.
done that. But Carmen, how long? Which?
Well, I think I would just take, I don't know about the guts of
Yeah.
it.
Yeah.
But I would, whatever she would. Yeah.
So, what would you think, Carmen? Half hour, 45 minutes?
Yeah, I think we could do a quick tour in as little as 20 minutes and as long as 45 minutes. It just kind of depends on how much information you need. So if you can only squeeze 20 minutes in there, we can get a quick tour in at 2. So we can make whatever work.
So any time of the day.
Yeah, if you just want to give me a call and we can schedule a time, whatever works best for you.
Okay.
Mhm.
Alrighty. Thank you.
Yeah, but you being a former CNA, I assume you didn't really want to see the guts. Yeah. Okay, great.
All right, we'll continue on. So item E under 6 is the central complaint survey. So we did have what's called a complaint survey in the central building at the end of May, is May 23rd, I believe was the date. So a complaint survey is an out of cycle survey. So it does not happen during our survey window. So it can happen at any time. So our annual surveys are always 9 to 15 months apart. As Scott mentioned, we're patiently waiting for our East survey, which is now over 12 months out, which is the average. So we're waiting for that, but this is a survey that's outside of that. So they can come in whenever. It's based on complaints that can be sent into the state, depending on the severity of the complaint and what the complaint is basically what bucket it falls into. They can come either within a couple of days, within a month, or within 2 months of the complaint actually being submitted. So we never really know when these are going to happen. It's typically 1 surveyor versus the annual survey is typically 3 to 4 surveyors. And normally complaint surveys are about a day long versus annual surveys, which are roughly 3 to 4 days long, depending on the survey. The complainants are always normally are anonymous, and they file a complaint about whatever they would like to file a complaint about. And then that is the only thing that the surveyors come in and look at. With one exception right now, all surveys that occur, actually not right now, at the time of this survey, this rule has now since changed, but at the time of the survey, all surveys that occur, no matter what the complaint is about, they will do an infection control survey at the same time, specifically focused on vaccinations. Since the staff vaccination regulation is new, they put that on every single survey, no matter what the complaint was. That, as of last Thursday, has since changed, and they are only going to do infection control surveys when it's attached to an infection control related complaint. So that was active at the time, but is not now. So the complaint itself was an anonymous complaint. They don't tell us necessarily what it is or what it's about. They ask questions. If it's about a resident specifically, they pull the resident's chart. They review the chart. They do all of that. The complaint itself was unsubstantiated with no citations, which just means that they looked at whatever the complaint was. They didn't see any issues with it. They did not think the complaint was valid or substantiated. And then they didn't issue any citations related to the complaint. We did, however, have a couple of minor citations related to the infection control survey, in part related to the vaccination part of that as well. Since that, one of the 2 citations has actually been removed based on administrative review by the state. So that's a good thing. So we ended up with just 1 low-level citation. One citation was related to goggle usage. So depending on or eye protection usage, I guess doesn't need to be goggles, could be face shields. Depending on the county's current transmission rate, staff would have to wear eye protection within the facility. And transmission rate is used for some things, and then positivity rate is used for other things. Those 2 things got mixed up, and then our staff were not wearing goggles when they should have been wearing goggles. So that was instantly fixed. There was no harm, no issues with residents, anything like that. So that was 1 citation, which we'll actually talk a little bit later about that one in the actual action section. Because any infection control related citations now come with what's called a directed plan of correction. So we have to write a plan of correction for every citation that occurs in the facility. We send that into the state. We send them in proof that we did the correction, and then that ends the survey basically. Then we get a letter of you are now in compliance kind of thing. And then we don't hear from them again until the next time. But so part of that directed plan of correction was a root cause analysis of why the citation happened, and it actually needs to be signed off on by the nursing home's governing body, which would be all of you. So we'll review that the actual root cause analysis later, which would then need to be approved by this committee and signed and sent back into the state. So that was 1 citation. The other citation that has since been removed, it was related to staff vaccination. The surveyor that was here at the time of the survey also wasn't sure if it was a citation or not, because it was kind of an odd situation. So our staff either have to be fully vaccinated or they have to have an approved exemption, either religious or health exemptions. All of our staff do have either an exemption or are vaccinated. The situation that came up was one of our staff members, actually an agency staff member, had an approved exemption and then decided to get vaccinated. So they had 1 dose of the vaccine and then they were delayed in getting the 2nd dose of the vaccine. So technically they were not fully vaccinated or up to date in their vaccines. And the surveyor said that the getting 1 dose of the vaccine made the exemption null and void. So we received the lowest level of citation you can get for that. And then we wrote the plan of correction, submitted it, did all the things with that. But then just earlier this week, I got an email from the state saying that that citation was removed after administrative review. So they said it was a really unique situation. The person had been out on leave due to a family emergency. So that is why they didn't get the 2nd dose. So they weren't avoiding it. They got the 2nd dose the day after the survey. So everything was fixed. It was done and we had no issues, but it was removed. So that is all good. None of these citations are anything that is causing any harm to residents. So that's kind of how the citation breakdown is. I should probably bring that chart sometime. So there's a chart that is what's called scope and severity. And it basically gives a letter to each citation. And that's the degree of basically how bad the citation is. And it depends on how many residents it affects. So that would be the scope. And then how much of an effect it would have would be the severity. So neither of these were on the severity levels that caused any harm or would have any reason to be suspicious to cause substantial harm. So they're low level citations. So they're on the low end of the chart. So one was an F and one was a C on the letter chart. But without that in front of you, I know that doesn't mean a whole lot, but so I will bring that next month to just show what those charts are as well. So that was the central survey, and then we'll be waiting for East survey soon.
So I got a question. So is there a time frame on these citations to be taken care of?
Yes, so all citations, whenever we have the survey, the citations are like in draft form, basically, until we receive what's called a statement of deficiency. So the state has 10 days, 10 business days to get us a statement of deficiency after the date of survey. Then from there, we have 10 calendar days to send in a plan of correction. So that's due to the state a week and a half after they send us the statement of deficiency. Then from there, it's typically 1 month from the original day of the sent statement of deficiency is when everything has to be corrected by. So we already have all of these things corrected. So we're sitting good for these things. The last thing is to have the root cause analysis signed today, and then that all of our documentation will be sent into the state later today. So they will all be cleared. We won't know that they're officially cleared until we receive a letter that comes from the state that basically says, we now consider you back in compliance.
So I'm assuming with citations, some that are worse than others, it's just would take a longer increment of time to do?
Yep. So some that are worse than others might have civil money penalties. That's the biggest issue with some larger citations. So anything with like an IJ, which is an immediate jeopardy, those are citations that caused actual harm to a resident or multiple residents. Those citations actually must be corrected before the surveyor leaves. So the surveyors could be in your building a while and you have to correct them before they leave. And then you have a plan to correct it going forward. So the plans of corrections aren't only to correct the actual citation that was seen or observed. It is also a plan to make sure it doesn't happen again. So that's where that comes in as a little bit longer for those, is the plan for it not to happen again. So fortunately, I should knock on some wood, we haven't had any severe citations in a very long time, but they come with civil money penalties. They come with directed plans of correction. If we did have a CNA training course, the high level citations remove your ability to have a CNA training course. So a long time ago, I want to say it was like 8 years ago. That was actually one of the reasons why our CNA training course ended, was because Central did have an IJ at that time. So then they could not have a CNA training course. So that was one of the reasons for our course going away many years ago. So that there's some different ways that they impose penalties on facilities if there are any severe citations.
I'm assuming the IJ person could be there any number of days, or is it a certain number of days?
So if a surveyor is there for an IJ citation, I shouldn't even say this, knock on wood again, I've never actually had an IJ, so I don't know how long it normally takes. Typically it's that they have a plan, they have to have the plan to correct it before they leave. So I don't think they stay like weeks or months or anything, but it might extend the survey a day or two.
Okay,
Mhm.
thank you.
Any other questions on survey? All righty. The last item on my report is COVID-19 update. So as you are all aware, from the past couple of months, we have had a few COVID-19 cases in the facilities in both staff and residents over the past month and a half or so. Unfortunately, all 3 of our neighborhoods did have an outbreak. On the good side of things, all of the residents that tested positive are recovered and are okay. We did not have any severe cases. Everyone had very mild symptoms. We had no deaths, no COVID hospitalizations, anything like that. So that's very good news, very different from some of our outbreaks in the past. As of today is the last day that the last household is in isolation. So if no one tests positive today, we will be outbreak free across campus. So we had one household still technically in outbreak. Their testings for that household was done on Tuesday. So that was their last round of testing for that outbreak. But today was day 14 since the last positive case of either staff or resident. So hopefully we will be out of the COVID woods for a little bit at the neighbors. We have seen upticks in staff cases, which it's been more than 14 days now, but that came along with the resident cases. We can't really determine if what came first, the chicken or the egg, but we have had staff be positive after outbreaks that could have been from the outbreak or could have started the outbreak, things like that as well. So we also have had quite a few contacts from families that are positive after they visited their loved ones, things like that as well. So it's just very evident that it's not going away. We keep seeing kind of bursts of community outbreaks in general, of kind of upticks in people being positive in our local community, which is how people then become positive at the nursing homes as well. But fortunately, it's much less severe than it has been over the past 2 years. So that's the big outlook on things, is that our residents that have tested positive are all doing well. So that's the positive news of that. Any questions related to COVID?
Just briefly, can you tell us and the people watching how, when someone has COVID, how it affects being able to admit?
Sure. So anytime that a resident has COVID or a staff person has COVID in that household, so anytime we're in an outbreak, whatever household was in outbreak, we're not able to admit to that household for that 14-day outbreak. Basically, it's so the people that are in that household were exposed to somebody that was COVID positive, whether that be a staff member or a resident. So we don't want to bring new unexposed people into that environment. So that is per regulation, we cannot then expose others because we haven't determined that the people that were exposed aren't also positive, and then we'd be exposing more people. So it's an effort to try to limit the amount of people that are exposed. But that being said, it does limit our ability to admit. So that's why earlier when I was doing the referral report, I mentioned that next month is going to look a little different because June was a fairly rough month for being able to admit. At one point, we only had one household on campus that wasn't in an outbreak. So that led us to only having one household to admit to, and that household was full. So we couldn't really admit anywhere. Our setup is very fortunate for this, comparatively speaking to say when this building was a nursing home, it would have been very difficult to separate the houses or the hallways. So it does help us that our neighborhoods are separate as well as our individual households being separate allows us to admit to one when the other one isn't an outbreak kind of thing. We can find places for people to go, which just makes a juggling act for our admissions team, but we make it work. If someone's supposed to go to Fireside, for example, and they're an outbreak, we find a room over in Tender Hearth. That's not an outbreak kind of situation, which is beneficial. But unfortunately, recently we haven't had any of our households that weren't an outbreak due to either staff or resident positive cases. So, and it only takes one as well to be considered an outbreak. So it is very limiting at times.
Thank you.
Any other questions for me about any of my report?
Oh, it looks like we can go on to 7.
All right, me again. So the first item on this on under 7 is the central survey root cause analysis. So I will review this. Basically, this is the root cause analysis for our complaint survey citation F880. So all of the citations are given a code. Basically, they're all considered F tags, but they all have a number. So F880 is the infection control citation. So this was the PPE usage for the goggles. So the steps for root cause analysis are 1, identify the event to be investigated and gather preliminary information. So the event that was to be investigated was PPE usage not matching the recommendation per county transmission level. Step 2, charter and select a team and facilitate a team to do and implement fixes, basically. So medical care subcommittee, so that's a committee of our QAPI or quality assurance steering committee, as well as myself, we're on that team. Step 3 is describe what happened. Proper PPE use was not being worn in accordance to CDC recommendations for county transmission level. Step 4, identify the contributing factors. Many maps and identifiers for COVID rates, so that there's a lot of different places to look for COVID rates and they all say different things. So that's one contributing factor. Delegation of duties related to COVID surveillance, having specific people look at one specific thing, and then simply human error, which I know is kind of not a specific thing, but that is really what it came down to, was human error. Step 5 is identify the root cause. So the root cause that we determined was both human error combined with not having a central location of saved information needed. So that is really I'll get to that. Sorry, I'm skipping steps here. Step 6, design and implement changes to eliminate the root cause, which we created a log that has the dates with dates and then correct information that needs to be checked on a daily basis. So that didn't only include this, but it also had anything else that we do related to COVID every single day. So every day we check our COVID tests on Exact Sciences, which is the lab we use. On their portal, we check those every day. Every day we update what's called EMR resource, which is the state's COVID /availability. It came through because of COVID, but I think it always existed for hospitals, but basically it's bed availability, so that we can put, if we have open spaces to take admissions through the hospital, that's a required thing through the state of Wisconsin, to have the state of Wisconsin CNAs in our building. We have to do partake in this program. So that's a daily thing that's on there, as well as checking the transmission rate is on there. and updating if we have to change testing frequencies is on there. And then calling Gold Cross, which is the transport service to take any tests that we have. So that's not an everyday thing, but an almost everyday thing that we have tests that need to be sent out. So all of those are now on a log that is on a shared drive that everybody on the clinical team, as well as myself, has access to update to make sure all of those things are done daily. And then we also have a shared document that has links to the proper map to be used for transmission rate, as well as general links that are available for COVID related situations. So it has the link for the number for Gold Cross. It has the link for Exact Sciences, all of those daily things, all of the links are right there. So someone doesn't accidentally go to the wrong website. And then step 7 was measure the success of the changes. So our current measure of success, our staff are properly wearing PPE at this time and all current logs are up to date. So that's our current measures of success. And then future measures of success are continued compliance of PPE usage. So we are doing audits to make sure that all of our staff are wearing the proper PPE at all times. Yes. So that is our root cause analysis for F880 for the Central's complaint survey, which does need action by this committee.
So any questions on what Carmen just went through or comments?
Sounds good to me.
So then we need a motion to
I'll motion to accept, to approve the report, the root cause analysis.
okay, so
I second it.
okay, so Supervisor Breslin moved and the Supervisor Witzel second. Any other questions, discussion? And again, to approve the analysis review and okay. All in favor? Any opposed? No. Well, thank you. That's kind of like a lesson in what it looks like. You've never had anything
Mm-mm.
brought to us like that.
No, this is the first time that we've seen a directed plan of correction, which is a new thing they're doing for infection control citations. So they typically only had those for really, really big citations, which we have fortunately, again, knock on wood, not received. So even though this is a low level citation, because of what FTAG it was, they have these specific directed guidance basically. So we typically do root cause analysis. We just don't have to have them signed off by governing bodies unless it's directed. So that is why it's being reported.
Yeah, well, it was interesting too. So you're going to be Jane today?
I am Jane today.
Oh my goodness. You have
So bear
vouchers?
with me.
Okay.
All right, so the vouchers were sent out. Does anyone have any questions on them at all?
Not on the vouchers.
Okay, I will
Okay.
pre-warn everybody for next month. The vouchers will have a couple of bigger ones in July and June and July are some of our biannual payments. So pre-warning for next month, there'll be a couple bigger ones. Those are things that are semi-annual payments. So we pay them twice a year. And they come in the summer months then for our second payment. So don't be surprised to see some bigger ones next month.
Okay, that's vouchers, now the financial reports.
Yep. All right, so if we want to start on the income statement, because I guess I don't know where Jane normally starts. That's how my brain works, is start with the big one first. So on the income statement, everything is fairly similar to what we've seen in the past couple of months. We have seen a little bit of an increase in census, so our numbers are a little better for revenues. We've also had an increase in Medicare census, obviously, since we've opened our short-term rehab. That helps us bump up that Medicare census, which is a higher payer source. So that's a benefit to us as well. So you'll actually see for the month, we actually were in above budget for the month. It still is below budget for annual for revenues, but for the month of May, we were doing pretty well with that. And then looking down, we always talk about the bistro still says 0 for revenues, but it also has 0 for expenses, which is just because our bistro is still closed. Senior meals is still doing pretty well. That's always a good thing. It's an added service that we do for the county, but it also does make us a minimal profit. The other items that are a little bit, you might see a little bit overages on. The MDS budget is over. That is primarily because our MDS nurses are picking up floor shifts. So they are working on the floor a little bit. So it separates their wages out into MDS and nursing. We've also looked at next year, just combining those two. Our MDS budget is just the 2 nurses that do MDS's wages. So if we just put them together, they are nurses. It's part of the nursing department. We don't do a separate budget for them. We're thinking about kind of looping them into nursing because it's part of nursing anyways. Completing the MDS is a nursing function, and their wages are part of the nursing budget. So, and they also do pick up shifts on the floor. So that's why that's higher in that bucket. The other things that are a little bit higher is we do have a little bit more of a pharmacy bill this month, which is higher than average. That is due to having more Medicare residents, that bumps our pharmacy up, but then those are also billed out through Medicare. So the higher the Medicare bill is, then we have that, as well as the other higher one is the operation and maintenance and plant. So that is one that sometimes gets higher or lower based on invoices that come in, are typically things that are one-time purchases that then that'll even out throughout the rest of the year. But it is a little bit higher this month. And then the therapies are the other thing that is directly related to having a Medicare census that is higher. We've been fortunate to be able to offer more therapy, which just has them up a little bit higher, but that's offset by the cost or the Medicare payments as well. So for the month, we did come out at net income. And then for the year before depreciation, we are at still at a net income of $90,000 prior to depreciation. But then when we add in the depreciation, you can see the bottom line there. But in cash flow wise, without the depreciation costs, we are seeing a net income. You have any questions on the income statement?
Could you remind us just briefly what the supplemental payment is?
Sure. Supplemental payment is payment that county-owned nursing homes receive, or public-owned nursing homes. I do believe if a city or any other municipality were to own a nursing home, they receive it as well. But most of the public nursing homes are county-owned. Receive what's called supplemental payment every year. It is typically we get 2 payments a year. These payments are things that are there to offset the loss from Medicaid for publicly owned nursing homes. Historically and currently, publicly owned nursing homes take more Medicaid residents than a private nursing home. This is primarily because it is seen as a service to the public in the county, as it's owned and operated by the county. So we do not take payer source into consideration when we're having someone admitted. So then we have a lot more Medicaid than a nursing home that looks at keeping their Medicaid numbers lower to offset the loss with private pay. So this is to offset our loss basically for having more Medicaid residents as a county-owned nursing home. Those numbers are derived from past years' cost reporting. So every year, all 3 of our nursing homes, we submit what's called a Medicaid cost report, which basically is about a 50-some page document that lays out all of our costs to care for our residents over the past year. It's part of our auditing process. So it's done by our financial team, and then Clifton, Larson, and Allen also helps with that as well. And then we send that in, and then it goes off of past years, then we get the next year's supplement payment dollar amount. So the number that we put in there is kind of a guess of how much they're going to give us, because we don't know in advance when we're doing the budgeting. So we go based on what our cost report looked like, as well as past years, what supplement payment has given us. So it's always a little bit off, whether it be more or less, just because we have to kind of guess what the state is going to reimburse us.
So if you're a private nursing home, you don't have to take Medicaid people? Is that correct?
They do take Medicaid people. Their censuses of a private nursing home would be very low if you didn't take Medicaid people. There's not enough people that have money to afford a nursing home. Nursing homes can range from $8,000 to $10,000 a month. So that very few people have money saved up to beyond that very long. So your census would be very low. But yes, there are nursing homes out there that do not take Medicaid. There's nursing homes out there that aren't even Medicaid certified. So they might just be licensed under the state as not Medicaid certified. They can't accept Medicaid. So that is something as well. That not locally here, there's none that I know of, but in bigger cities where there's people that can afford to pay $8,000 to $10,000 a month, there are certain places that are only certified for Medicare. So then it would be Medicare and private pay.
Thank you.
Mhm.
I was just
Supervisor Keeter?
wondering, is the supplement that you get from the state, is that different from the so-called Medicaid state payment? Because I know the one that they used to talk about in the county board meetings is for a while, we were 50th in rating, the 50th
Yeah.
lowest. Is that the supplemental one or
No,
another one?
no. So the thing that we're still near the bottom. We're not the 50th
Yeah.
anymore.
48 or something
yeah.
like that.
Yeah, when I first started here, we were the fifth, that Wisconsin was the 50th of the 50 states.
Yeah.
That is for the actual daily rate. So
Okay.
that's the rate that we get from Medicaid. So that would actually mean supplement payment was higher because they're supplementing the rate that the state isn't paying up front for the Medicaid resident. So Medicaid has changed their payment system to be more like Medicare, to pay by resident. It's still a much lower payment than Medicare, but the system is more viewed at by resident instead of a general rate number that we used to get for everybody, no matter what their care needs were. But Wisconsin is still fairly low. I know we're in the bottom half. The company that used to put out that listing doesn't do it anymore. So I don't know exactly where we are on there, but at a recent meeting, they did mention that we're still near the bottom. We're not 50th anymore, but which is fortunate because we have had a couple of larger increases in the past couple of state budgets, which has been good. I know the associations are going to be putting out a pretty hefty ask this year for an increase with the new budget that'll be coming out. Well, it'll be next year's budget, but they've already started the process of lobbying and doing all of those different things to help increase that as well. Because as the cost of care goes up, as wages go up and food goes up and everything else, we want to make sure that our rates go up too, so that we're still sustainable. Any other questions on the income statement? Okay. Now we can flip to the pool staff. This is the kind of multicolored sheet. So you can see that as we've kind of talked about in the past, it's almost every other month they're higher and lower. That's just due to when bills are paid. So that's why it kind of flip flops. So we kind of go somewhere in the middle of last month and this month, that's the actual monthly average just based on when invoices get sent in and things like that for our pool agency staff. So it kind of fluctuates up and down. Centrals did go up. That is primarily because we have open Fireside. So we have 2 households in Fireside. So some staff that were in other parts of the campus were moved there. So that number did go up a little bit. And then the other ones are up because of the offset of the couple of different months. So this month was 400,000, say for West, and last month was close to 2. I would say that's normally actually around 3, but just because of invoice processing, that is why those are off. Any questions at all about the pool staff?
What do you have for a budget for this year for pool staff?
I don't have that.
Close to last year's numbers?
Yes, so we did it close to last year's numbers. Last year and this year, we had done a different viewpoint on how to budget for pool staff. In the past, we were budgeting pool staff kind of separately to our staff in the PEP because we had, it's a little bit confusing, but the overall PEP spreadsheet, we had all these positions, and then we were trying to put a guess on how many positions we'd have to fill with pool staff. This year and last year, we've budgeted separate buckets of money. That is the difference between our staff and pool staff, instead of trying to take numbers out of the PEP and then add in money and do it that way. So we're still kind of building that budget view because we've only had, this is only the second year that we've done it this way. So hopefully this coming year, we'll have a little bit better handle on how to budget for that, because we're still trying out a new system for budgeting for that. Because before it was trying to pull someone off of the PEP and then putting it into a pool position, then adding a random number basically to try to make it a pool number. And then now what we're doing is we're keeping the PEP, and then we're just adding in extra dollar amounts to the pool staff, so that the difference between a pool and an in-house person, so that we don't have mixed up budgeting for that. So on top of this pool staff number, would not match the budgeted for pool staff, because this would also have the half or 60% of this number that would have been budgeted in the PEP.
Okay.
So it's a little bit confusing because we're still budgeting as if we're fully staffed with our staff, and then adding in the extra cost of the pool staff as a separate budget. So that would only be the budget for pool staff would only be an additional dollar amount compared to what we would pay for our own staff.
Which it still looks like we have maybe to the end of June, end of this month, maybe July left then, before we could run into issues.
So it would still come out of the overall, so how it would all come out of the overall nursing budget. So just because we had more, we aren't gonna run into like a budget error issue yet.
Okay.
So because
Yeah.
it all comes out of the overall nursing budget. So it would, if we have more pool staff than what we were anticipating, it would come out of what we had budgeted in the PEP.
For the PEP.
For the PEP, yep. So it's not a separate cost center. It's all in the nursing cost center for each building.
I just wanted to make sure we don't run into
Yeah,
issues come September, October or something.
no, as of right now, we're doing okay when it comes, because it still comes down to the overall cost center bottom line. All right. Any other questions for pool staff? All right. Oh, sorry, I hit the mic. The aging report. So as you can see, the aging is a little bit up. That is due to having higher census, especially our Medicare census. These are also because of the days that the bills get sent in. If we have our Medicare bills sent in by the 10th of the month, we'll receive them the same month. If it's after the 10th, we receive them the next month. So a lot of these bills are about a month behind because the bill didn't get sent in. So we still will be paid for it. It'll still come through. It'll just be delayed. That is partly because we are still adjusting to having a Medicare census. A lot of our business office is new. So they have not been here when we have had a high Medicare census. And one of the individuals that is new is her primary role is billing for Medicare and other insurances. So she's adjusting to having a higher influx of claims and things like that. So we're hoping to get those in before the 10th, but we're still training and adjusting to that. So we'll still get paid for them. They'll just come a little bit later. We do have a couple of outstanding bills for a couple of residents from either resident liability, co-insurance, if they were Medicare, their copay, or some private pay. So we are working on a couple of bigger buckets of money for those individuals. So those we're working on collecting from a few families for a couple of things too. So that's the other bucket of a little bit higher claims as well. So any question on aging?
Quick again, I just want to make sure I understand what's going on. I'm looking at the very last one, the one that goes through May 31st, the bottom one.
Sure.
And so when it says transaction amount, that's the amount of money that was billed. Is that correct?
Mm-hmm.
Okay. And outstanding balance, that's everything owed for the last 100 years or whatever that we haven't.
Correct.
Okay. Thank you.
Yep. Any questions?
So this is kind of like an accounts receivable?
Yes.
Okay.
Yep. Yeah, so it's like accounts receivable, and it's basically that we keep track of the age of all of the accounts because there's a certain bucket of time frame that's the best time to have them collected, or you're most likely to collect on them. And once it's past a certain amount of days, it's very unlikely to collect on them. So we keep an eye on where our biggest buckets of money are and make sure that they're in those buckets that are still likely to collect. So that's the idea of this, is keeping track of how much is owed to us and how much we can still reasonably collect. Because if there's things that we can't collect, then we get into write-offs and things like that, which we don't want to do.
So you can rebill? Can you rebill on some of these particular items or no? Like send them back to insurance again to? Maybe.
So if it's insurance or Medicare, Medicaid, any payer source that's not a person, there's timely filing limits on those things. So if we were to miss a timely filing, we wouldn't put that on here. That would be written off because we wouldn't be able to collect. These are only things that we can still collect. So a lot of these, the ones that are shorter term, are bills that either just haven't been paid yet, that are in processing. So Medicare, it's out there for Medicare, VA, Humana, any sort of insurance company like Humana, Blue Cross, Blue Shield, whatever insurance, Medicaid, things like that. The ones that are further out would not be insurances and things. It would be private pay or co-insurance. So if someone is in for Medicare and they're there for more than 20 days, they start paying 20% of their Medicare rate. So Medicare only pays 100% for the first 20 days. And then after that, they only pay 80%. So then if the individual has co-insurance, like a privately purchased plan, then that would kick in. Otherwise, they're responsible for that 20%. So the stuff that's further out is all for billing a person, not a company.
Okay. Thank you.
Any other questions on the aging?
How aggressive are you at going out after the over 180?
It depends on the situation.
Okay.
So if it is someone that is deceased and we don't have contacts with people, obviously there's not much we can do. If we have someone that's currently in the facility, that's a whole nother situation. For example, one of them that's here's the current resident. We go through the process of issuing letters. We talk to them, we try to assist them. A lot of our people, either if they are still their own financial power of attorney, they're in a facility, they don't have a lot of access to getting things they need. So we try our best to help them pay us basically. But then we also then we have to issue letters of notices of saying this is your first letter, your bill's due on this date. We go through that process. And then at the worst case scenario, if we're still not paid after going through our whole accounts receivable process, then we would issue what's considered a 30-day notice, which would be a 30-day notice due to non-payment for them to be discharged from the facility. We don't do that lightly and we don't do it often. It is definitely something we try to avoid at all costs, because once they leave the building, we're probably not getting paid either.
Right.
As well as it's not the best thing to do, both for public relations for the community, as well as we have to find a location for them to go. So you can't just put someone out on the street, which we wouldn't want to do, but how the regulation is written is if we issue a 30-day notice for any reason, there's only a few reasons we can do it. But if for any of those reasons, one being non-payment, we have to find a location for that person to live that is suitable and safe for them. So we can't send them to a shelter. We can't do something like that. We have to find a location that is suitable and safe. So whether that be a different nursing home, an assisted living, a family's house, things like that, we have to find a location. Which, if it's in their charting that they haven't been paying us, another nursing home isn't going to take them either.
No.
So that's the whole process with that. So we try our hardest not to do that for any reason, but it does happen at times.
I was just curious, on the average, do you write off quite a bit each year or?
On the average, no, that's what we try to avoid a lot. That's a huge thing that we try to avoid is writing off. We did have quite a bit of write-offs. That was probably now 2 years ago, due to timely filing issues. That is one of the issues that comes up when we're short-staffed in the finance department. In between our, it's now 2 accounting managers ago. So Leo was here for a long time. In between her and Jane starting, we did have another employee in there for a brief couple of months. I tried to get it fixed up, but she went back to her previous position. But during that time, we had a lot of timely filing issues because we were short-staffed in finance and things weren't getting done. So we had more write-offs that year than normal, but we don't have a lot of write-offs. It's we try whatever we can to collect the money and make sure that we're doing everything on the timely filing stuff as well on time. So.
Okay.
All righty. The census sheet is also in here, I believe. So that just shows our census and broken down, by payer source. So as you can see, Medicare A is above our targeted line, which are the lines across, which is great. Private pay is down, but it is consistent and it's a little bit higher than earlier months of the year, but that is down. Medicaid is also down. That is okay, as it is our lower payer source. We'd rather have Medicare high, so that's a good thing. Veterans is above target. We have had quite a few veteran admissions this year, which that's always just kind of hit or miss what we're at for veterans payments. So yeah, is there any questions on the census?
No.
Okay. The only other thing that I had for financials was it's kind of represented on the income statement, but I forgot to mention it, is our fundraising efforts. So we do have a bunch of fundraising events that we've been doing. I know I've talked about it in the past. Our most recent one was the pie sales. at the Ludington Guard Band concert, which we're very happy to say we made $1,200 at the pie sales. So that was a really good fundraiser because it had little to no cost to do the fundraiser, which is not normally the situation. You have to put in a little bit of money to then fundraise money, but that one was all volunteer as well as mostly donated pies. So we have a huge thank you out to everyone who donated pies or stopped by to have a piece of pie. So it was a great event. Our next big event is we are doing a golf outing in August. So if anyone's a golfer, we have a golf outing in August. That'll be a 4-person scramble, which is a fundraiser for the bus as well. So as of right now, we're over a third of our way to our goal. For our original goal is $90,000. So with the pie sales, we're almost to $40,000, I believe. So we're still working away on fundraising for a new bus. So, and some of those dollars are recognized in the income statement for the miscellaneous revenue stuff that's fundraising. Any other questions for financials?
Very good
Anything?
job.
Thanks.
Yeah, yeah.
Yeah.
Okay, then we need to have a motion to accept the financials.
I so move.
I'll second.
Supervisor Witzel and Supervisor Breslin. Anything else? All in favor?
Aye.
And unanimous. And that's that. Anything else? Any supervisors have any announcements or? No? Then we are adjourned. And thank everybody for asking questions. It really helps me. I know that.